our hi everybody. I just want to make sure that I didn't cut myself off at the beginning. My name is Brooke Rossi. I'm one of the doctors at Ohio Reproductive Medicine, and I really appreciate you joining us for the Facebook Live webcast tonight. Sorry about the wait. We had a little bit of technical difficulties, but it looks like we're off and running now, and I really appreciate you taking time with us tonight. So we have a chat box open that you can submit questions to. And I'm also excited to go through a few questions that people had sent ahead of time. And one of the things that there's kind of a theme to a couple of these questions. And one of the things that I think is worth discussing, it's always a question that patients have, is about genetic testing of embryos. And so I just want to spend a couple minutes talking about that. First, I want everyone to understand, like, what is the whole point of genetic testing of embryos? So one of the things is that we want to try to make IVF more efficient and more effective by trying to understand which embryos are genetically normal. And it's very important that we understand what this genetic testing can actually do. It can only look to see if the embryos have the right number of chromosomes. So doing PGT-A, for example, which is probably the most common type of genetic testing of embryos, has to do with seeing if the embryos have the right number of chromosomes. It doesn't look to see if an embryo is going to give you a healthy baby. It doesn't look for things like autism. It only can look to see if the embryo has the right number of chromosomes. Now, an example of that would be for example, Down syndrome is a condition where a pregnancy does not have the correct number of chromosomes. It has an extra 21st chromosome. So over the years, like literally over like 15 years plus, there have been different variations of this test. Back years ago, when I first started doing this, they used to only test day 3 embryos. They found out that that test was not any more effective than not doing testing. Now we do something called blast-assist biopsies, which means that the embryos are biopsied on day either 5, 6, or 7. Most of the time, depending on where you are in the US, but at least in Ohio, there are not any clinics who can do the testing in-house. So the embryos get biopsied, the embryos then get frozen, they stay at the clinic, and the cells get sent for analysis. And then you'll get a report, or your physician will get a report, somewhere around 2 weeks or so later, letting you know which of the embryos have the right number of chromosomes. And it's actually quite specific. It will tell you which embryo, like the actual chromosomal abnormality, so it's with the embryos. And then that information can be used to help you and your physician decide which embryos should be transferred, if any. So this is a great idea in theory. The idea is that we can somehow help people have a higher chance of getting pregnant. But it's very controversial, and there have been lots of studies over the years trying to understand exactly who benefits from this. So sometimes people will consider it if they are in their mid to late 30s. So for example, it hasn't really been proven to be overall effective for women who are less than 35, because those women already have a very good chance of having chromosomally normal embryos. So sometimes people have other reasons for wanting to consider doing genetic testing. Sometimes they've had a history of recurrent pregnancy loss and think that that may decrease their chance of having a chromosomally abnormal pregnancy. Sometimes they have had an experience where they've had a chromosomally abnormal pregnancy before. And sometimes they are concerned about their age, and maybe those patients only want to have one embryo transferred, and therefore they are trying to make sure that one embryo is genetically normal. So there's a lot of different risks and benefits of doing that testing. It can sometimes be more expensive and often not covered by insurance. There could be a theoretical risk of a negative impact on the embryo from the biopsy. So it's really important that you talk with your clinician or physician about whether it's right for you, and you have a very honest conversation about the limitations and the benefits for you specifically in terms of the testing. So one of the other questions that we received ahead of time was about I'm going to actually say it's about metformin, maybe indirectly, but metformin is a medication that is used for diabetes, but is also an off-label use in patients with polycystic ovary syndrome or PCOS. And a couple patients indirectly asked about metformin. One patient asked about ovarian hyperstimulation syndrome and how that can be prevented in patients who are considering in vitro fertilization. Ovarian hyperstimulation is when there is an overresponse of the ovaries to the IVF medications. Ovarian hyperstimulation technically can occur in other forms of infertility treatment, but it's really most concerning with in vitro fertilization. And ovarian hyperstimulation, you know, in 2023, it should be a very rare event because we have lots of studies and information now about ways we can prevent it. Some of the things that may put people at risk for ovarian hyperstimulation may be a young age, having polycystic ovary syndrome, having an elevated AMH somewhere above about 3.3 or 3.4, having a history of ovarian hyperstimulation. And so if you're considering in vitro fertilization and you fit that profile, it's really important that you and your doctor recognize if you could be at risk, and then also if you could be at risk, and then sort of what kind of things could be done to help reduce the risk. And there's a lot of things we can do to help prevent the risk. One of them will be, and this gets back to the metformin that I talked about. So there are some studies that say that metformin may reduce the risk of severe ovarian hyperstimulation during in vitro fertilization. And that's not something we do for everybody, but so for example, if a patient was very high risk, or maybe they had it in the past, that would be a reasonable thing to consider if you know, they wanted to reduce the risk even more. Being very thoughtful about the doses of medication so that patients don't overstimulate, close monitoring during the cycle. One of the, I think the other there are three really important things that help prevent the risk of hyperstimulation. One has been something called a GnRH agonist trigger, or we call a Lupron-only trigger. And so for those of you who are considering IVF or have been through it before, you know that last final thing, the trigger shot, helps mature the eggs. And for most people, they can use a Lupron-only trigger, which causes the body to make a big surge of LH, which helps mature the egg and allow us to go ahead and get it at the time of the retrieval. And because that LH doesn't last very long in the body, the risk of getting ovarian hyperstimulation with the Lupron-only trigger is exceedingly low. The second thing that's probably most important is we will use a medication often called cabergoline. Cabergoline is a dopamine agonist, and that class of medication also helps reduce the risk of moderate to severe hyperstimulation. And then I would say the other very important measure that we can take is to do something called a freeze-all. So ovarian hyperstimulation is all mediated. I mean, it has to do with how much somebody is responding, but it's actually mediated by HCG hormone. So that's what's in the trigger shot, right, for most people. But it's also the pregnancy hormone that's released when you get pregnant. So if someone's at risk for hyperstimulation and then they get pregnant with a fresh transfer, their hyperstimulation can get very severe. So sometimes what we'll say is, you know, you will have a better chance of getting pregnant, because that's the other thing too. When somebody's overstimulated, they actually have a lower chance of getting pregnant with a fresh embryo transfer. So we'll say, listen, you have a better chance of getting pregnant with a frozen transfer, and it's safer. So those are all the different things that we can consider to help reduce the risk of ovarian hyperstimulation. But the question was, you know, how can does metformin help? And the answer to that is yes. There is a question from one of the participants. Looking at, I actually think this is really interesting. So someone has a question related to using, this is about frozen embryo transfers. So frozen embryo transfers, when embryos have been created, And then we're going to use those frozen ones. And that's a very common thing in the world of IVF. In general, fresh and frozen embryo transfers have about the same success, but there are many reasons why people may have to do a frozen embryo transfer. So again, most of the time, if you're doing genetic testing, you will result in having a frozen embryo transfer. And if people have an elevated progesterone around the time of a trigger shot, or if they have a polyp or anything happens in the cycle where they actually may have a lower chance of getting pregnant with a fresh transfer, we would consider doing a frozen embryo transfer, because we know that embryos and success rates are very good when we do a frozen embryo transfer. But one of the participants tonight asked about progesterone and oil or vaginal progesterone with a frozen embryo transfer. Now, for anyone who's ever done IVF before, you know, there's all these like hated things in the world of infertility, including things like a fallopian tube test, you know, endometrial biopsy, progesterone and oil. So progesterone and oil, it's kind of a necessary evil in the world of infertility and IVF treatment. It basically means that the progesterone injections are given in the gluteal muscle. So it's like in your butt muscle. And the progesterone has to be put in an oil. So it's kind of, so it can be preserved. But it can get really sore and tender, and people have to do it for a long time. So people do it, but they don't like it. And some of the studies over time have shown that there may be benefit of doing progesterone and oil compared to other forms of progesterone. But there was a very interesting study that came out several years ago looking at vaginal progesterone versus vaginal progesterone and intramuscular progesterone, like intramuscular progesterone every 3 days with vaginal in between versus progesterone intramuscular every day. And they found that giving intramuscular progesterone every 3rd day was just as good as giving it every day. So sometimes if I have patients who are really not liking progesterone and oil, that is sometimes a technique that we'll do. Now, the other thing that you could think about doing is to talk to your clinic about a kind of like a modified natural protocol for a frozen embryo transfer. Because in those, what that means is that, you know, there's some sort of protocol where your body is making some of its own progesterone. And sometimes when the body is making some of its own progesterone, maybe intramuscular progesterone is not necessary. So that's another option as well. There is a question from one of the participants about getting infertility coverage through their insurance. So I want to talk about this because this is actually a question that I get all the time. People will say, well, which insurance plans cover infertility? And it's actually not the insurance plans that carry infertility. It's the employer that decides if they will cover infertility benefits for their employees. So you could have medical mutual and have coverage, or have medical mutual and not have coverage. It's all determined by the employer. And there are different companies, I mean, you know, big and small, that will cover infertility treatment for their employees. And that's something you could always talk to your human resources team about. Every once in a while, there's, you know, a different employer that offers benefits that maybe didn't before, like the state of Ohio, just in the middle of July, started offering infertility benefits to all the state employees. So, and some of them didn't even know that they had that benefit available. So the other thing you could always do is you could always talk to your employer. I mean, you know, in many situations throughout the country and throughout time, infertility benefits get added because patients make a fuss. So it may be something, and I've definitely had patients who have rallied together and talked to their employer and let their employer know how important it is, and they have been able to get employee benefits. So, you know, it's one of these things where you would think that people would know about it, but sometimes employers don't. So if it's really important to you, you know, approach your employer and see if that's something that's a possibility. I'm just reading, guys. I'm sorry. I have to like read the little comments here every once in a while so I can continue the conversation. I want to talk about two different things, because I think these are often questions that we get and also a little bit confusing. So one of the attendees asked a question. I think maybe the gist of it is about ovarian reserve. Like, so there are different ways to measure ovarian reserve that talks about sort of how many eggs are left compared to other women your same age. So ways to measure ovarian reserve might be an anti-Müllerian hormone level, might also be an FSH level, antral follicle count. And so measuring ovarian reserve versus infertility. And I talk about this a lot with people. So in the world of infertility, or in the world of, I guess, trying to get pregnant, probably age to some degree is the most important thing. And when young patients, so let's just say women less than 35, have a low anti-Müllerian hormone level, that might mean that they have less eggs left compared to other women their same age. And there's pretty good data that an AMH level may not necessarily dictate fertility, may not be the reason why somebody's not getting pregnant, also may not be associated with things like miscarriage risk. In fact, there's a very good study that has come out recently that looked at chance of getting pregnant with insemination at different AMH levels, and there appeared to be no association. However, AMH level is very closely associated with somebody's success with IVF, because AMH level is very associated with sort of how someone's response will be with IVF. So if we had, two women who were 34, one who had an AMH level of 3.0 and one who had an AMH level of 0.3, the woman with the 0.3 might need more medication, might get less eggs, and then because she has less eggs and then subsequently less embryos, ultimately has a lower chance for that cycle. So they're really, I think it's important to understand that, to not get too worried or kind of freaked out about the AMH level, one, because you can't really do anything about it. If somebody has a low AMH level, they didn't give it to themselves. It can't really be changed. And also to understand that it doesn't predict fertility. So I have, at different times seen patients who have been referred because they had a low AMH level. And sometimes these people haven't even tried to get pregnant yet. And, it doesn't necessarily is not related to fertility, but you also can't really totally ignore it, because you do need to understand the implications it has for infertility treatment, like in vitro fertilization. And, I think also you have to be a little bit thoughtful about maybe big picture planning for those patients too. One, they need to have an evaluation for why they might have low ovarian reserve, especially if it's quite low, like if it's less than 1 or less than 0.3. There are some different genetic diseases that could be associated with decreased ovarian reserve. And so it's just important to understand, sort of like put it into context. One of the other questions that someone had asked about was a little bit about, she kind of has a question about like naturopaths and holistic doctors. And I don't know, I had this experience recently where I was just kind of looking at Facebook, and there was an article that came out recently in like The Economist magazine, and it's about infertility treatment. And I saw it posted, and I thought, well, let me just read what I want to see what the comments say about this. And it kind of made me sad, because a lot of the comments from just random people were things like, and these weren't necessarily patients or doctors or anything, just like, people who had posted on this were, saying things like, well, if people just ate better, they would get pregnant. And, kind of all these things that were almost, I don't know, it kind of made me feel like maybe they were saying that if people just did certain things, like then it would all be fixed, and they were kind of blaming them. And I felt bad that that was the perception of these people. And, I think that there are definitely things that sometimes patients can do to help optimize their chances of getting pregnant, either on their own or with treatment. You know, I mean, there are some pretty clear things we know affect fertility, like, you know, smoking or heavy alcohol use, and, you know, trying to maintain a healthy weight and trying to have, you know, eat healthy foods and have a good environment and all of those things. I mean, all of those things are important. But, you know, if that was the only thing that caused infertility, or those were the only things that people needed to do, I wouldn't have any of the things we have here to help people get pregnant, you know? So I think I never mind when people are doing things like acupuncture or trying to be healthy, or, you know, even seeing a holistic doctor, as long as sometimes they're not trying to manipulate the hormones or anything, if I'm trying to manipulate their hormones. But I think that those things can be used in tandem. You know, a lot of times, like I think that some of the care that people get from other types of practitioners may be helpful. I mean, it's also naive to think that, you know, there are many parts of the world that people do other types of treatment. And so I think a lot of these treatments can be done in conjunction with what like quote, Western medicine is. But so if you are doing any of that stuff, so one, don't feel bad if you want to go see a holistic doctor. Talk with your Western medicine doctor about how, you know, that can be kind of done together. And also make sure you're telling your doctor if you're doing anything, because you want to make sure that, again, what you're doing is consistent and not affecting anything. I wanted to talk just real briefly about a question about adenomyosis. Ahead of time, there was a attendee who had a question about adenomyosis, and I wanted to just discuss that. I'm not sure how many of you know what adenomyosis is. So adenomyosis is probably kind of similar to endometriosis. So endometriosis is when we call them ectopic endometrial cells. So the word ectopic, you've probably heard in the context of ectopic pregnancy. So ectopic just means that something that's supposed to be in one place ends up in another place. So ectopic cells, so the lining of the uterus or the endometrium, those cells end up in other places in the pelvis. That is called endometriosis. Sometimes it can be on the surface of the uterus or the ovaries or the surface of the pelvis. And then when it's actually in the muscle of the uterus, it's called adenomyosis. And adenomyosis is probably even harder to understand than endometriosis. Adenomyosis is very difficult to diagnose. And for years and years, people couldn't diagnose it because they didn't have any good tests for it. Because you actually need, it's not like when you look for endometriosis, you can see it. You sometimes can't see it by actually looking at the surface of the uterus, even during surgery. It's gotten better over the years. People can now diagnose it sometimes with ultrasound or with MRI. You can see different kind of like suspicious regions that may look like adenomyosis. People with adenomyosis have pretty bad bleeding and pain with their periods. And it can be very hard for those patients. And it can also affect fertility because of the inflammation that is around these areas of adenomyosis. Sometimes adenomyosis can be what they call focal, which is where there's like kind of like pieces of it or chunks of it in certain spots in the actual muscle of the uterus. And then sometimes it's diffuse, which means it's just kind of scattered all throughout. But you know, the problem with adenomyosis, if there's like a focal big chunk of it somewhere, sometimes it can be removed, almost like how we would remove a uterine fibroid, like surgically. But they're very hard. I mean, it's very hard to remove them because they kind of invade into all the tissue around. And so this attendee's question was, you know, what are options for someone who may have this? And I think the first thing to acknowledge is that, you know, this is a really challenging question, and it's not totally clear what is successful. One of the things that people have always kind of debated back and forth in our field is the role of medical suppression of either endometriosis or adenomyosis in the setting of doing treatment. And this comes up kind of all the time with even endometriosis too. So any sort of endometriosis or adenomyosis, it's suppressed by medications that make estrogen low. This is why we often would use things like birth control pills for suppression, or a medication called Lupron, or a medication called Digestin, like anything that kind of suppresses estrogen. But anytime you do an IVF cycle, what happens, right? Your estrogen goes way up. So it can be kind of an inflammatory state. And so sometimes either with endometriosis or with adenomyosis, if patients aren't getting pregnant, sometimes we'll try to do a cycle where we then freeze all the embryos or bank the embryos. And then we try to do something to kind of quiet down the adenomyosis or endometriosis. So sometimes that can be done with different types of medical suppression. Sometimes it can be birth control pills, Lupron. And the idea then is that if you get it all calmed down and suppressed, that maybe you will have a higher chance of getting pregnant if the embryo is then transferred right after the suppression. And again, that usually is done in the setting of a frozen embryo transfer cycle. So I think if you are a patient with either adenomyosis or endometriosis, it may be worth talking to your clinician about if does it make sense to do any sort of suppression of endometriosis before doing an embryo transfer. And it's not right for everybody. I mean, we don't totally know exactly how endometriosis or adenomyosis affects success with infertility treatment, or how it affects infertility in general. Sometimes it has to do with inflammation and sort of how then the sperm and the eggs and implantation happens. Sometimes we think that it can affect the receptive window of the embryo. So anyways, these are all different theories, and we need to know more about endometriosis, and we really need to know more about adenomyosis. So it can be a real challenge. So I definitely talk with your clinician about that. Let's see. So we have another question about, does each round of IUI increase your chances of getting pregnant? And I'm just going to expand that to say, does each round of anything, IVF, IUI, whatever you're doing, frozen embryo transfer, does it affect your chances of getting pregnant? Not usually. Usually you have the same chance of getting pregnant each time you try something for a few tries. So what I mean by that is most of infertility treatment studies, and most studies done on different types of infertility treatment, will look at something called a cumulative pregnancy rate, which means that, let's say they take 100 people and they put them all through a frozen embryo transfer cycle, okay? And let's say 40% of those people get pregnant, and the next 60 go through, and another 40% get pregnant. And they take who's left, and another 40% get pregnant. And whoever's left in that group, probably has a lower chance beyond that, because that particular treatment isn't working for them. So it's not that people's chance of getting pregnant goes up or down. It's probably about the same for the first 3 or 4 times they try something. But then if you're still standing with the people that haven't gotten pregnant after 3 or 4 tries of something, it could be that it's worthwhile talking to your provider about whether a different treatment is right for you. Because you should be saying, why haven't I gotten pregnant in 3 or 4 tries of something? Are we missing something? Is there a different treatment we should be doing? So that's a common question that we get. All right. I'm going to ask, somebody asked a question about egg freezing. So this is a good question about egg freezing, because for our patients who are interested in that, sometimes they are not interested in, maybe they'll have some sort of contraception and an IUD. Most patients who have an IUD actually continue to cycle even though they're not having periods. So the way that the IUD works doesn't really affect ovarian function very much. So as long as we know kind of where your ovaries are at in their cycle, we can go ahead and do the retrieval. And there's plenty of studies on egg donors and women freezing eggs, and you definitely don't need to have an IUD removed before doing any type of fertility preservation. All right, let's see here. Let's see. Sorry, guys. Hold on one second. I'm going to talk a little bit about, so there's a question about in vitro fertilization versus intracytoplasmic sperm injection. So we kind of call that IVF versus ICSI. And ICSI is indicated for some specific medical reasons, and conventional IVF should be done sort of for other patients. So conventional IVF is, what that means is on the day of the retrieval, we get the eggs. The eggs are put in a dish with probably about, I don't know, 50 to 100,000 sperm. And then they're put in the incubator. And then the next day, the embryologist will look at them, take some of the cells off the egg, and see if that egg has fertilized. So basically, the sperm is allowed to kind of fertilize the egg itself. So that is a great option for patients who have normal sperm counts. ICSI is a procedure that is indicated for, really kind of started being used for patients whose sperm has a low sperm count. So in that procedure, we take the eggs on the day of the retrieval. The eggs have to be stripped of some of the cells, and then one sperm is grasped and then put directly into the egg. And that is primarily done for, again, issues with sperm quality, might be sperm count or poor motility, also with surgically retrieved sperm. So for example, like if a man has had a testicular biopsy or a sperm aspiration, they need to have ICSI. ICSI is also used with frozen eggs, but it doesn't have to be. There's a lot of other like sort of things that people say. Sometimes they use it. They say, well, should we do it if we have a low number of eggs, or should we do it if, you know, the woman is older? And there hasn't really been solid data that you need to do it in those situations. I would say the other downsides of ICSI are that it's often more expensive. I mean, it is another procedure done to the egg. So for some patients, there's another charge for that. And there was a study that came out recently, actually, also that showed that patients having ICSI without male factor infertility still had a slightly greater risk of birth defects compared to people without male factor infertility who did conventional IVF. So in general, as you guys probably know, there's a slight increased risk of birth defects with IVF. And that's a little bit higher even with ICSI. Sorry, I also need to just. So I would say, I mean, so my thought is, you know, if there's any concern with the sperm quality, like if you're really worried about having an issue with fertilization, I mean, if you need to do ICSI, you need to do ICSI. But I often am thoughtful about doing it just because I don't, you know, want patients to spend extra money. And I mean, it might potentially increase the risk of birth defects as well. So it's really important to talk with your clinician about, you know, do they do it at the clinic, and what are their medical indications to do it? Okay. So somebody had a question about embryo quality and implantation. So let's talk about that a little bit, because I think one of the things that patients are asking more and more about now is they want to know how their embryo quality is. They want to know what's the grading of their embryos, okay? And there are definitely different grading systems for different clinics. So if, you know, just understand, like if you ask your clinic, like, hey, I want the grade of my embryos, and they say, well, it's a 4BB, or they may say it's a something else, like, let's understand that there's something called the Gardner criteria, which is like, it's a pretty standard way to do it, but it's not what everybody does. That's the one where they give you like the number and then the letter and the letter. So the number is the stage of blastocyst development. Blastocyst means it's the stage that the embryo should be at about 5 to 7 days of life. And then the letters, one of them describes the quality of the cells in the trophectoderm. The trophectoderm is what becomes the placenta. And then the other cells, the other letter talks about the cells in the inner cell mass, and the inner cell mass is what becomes the fetus. So just that's what they mean when they say, like, 3AB or 4BC. It's the stage of blastocyst, and then, like, what the cells look like. So the only thing that determines, like, that tells us about implantation potential. So the grading of the embryo talks about implantation potential. It doesn't tell you about a healthy baby. It doesn't tell you whether it's genetically normal. It only tells you about its potential to implant. So that's kind of the point of the embryo grading. Now, one of the sort of other caveat to the other part of this question the person asked was, what would cause a high quality embryo to not implant? So when I think about this in kind of I think about getting pregnant with IVF, like, why doesn't it work? I think about it in 4 categories. 2 are related to the embryo, and 2 are related kind of to the person, to the woman. So in regards to the embryo, 1, the embryo might not be genetically normal. So even if it looks beautiful underneath a microscope, it's a 5AA, it could still have the wrong number of chromosomes and not give you a pregnancy. So that's number 1. 2, it could be genetically normal, but maybe there's something else going on with the embryo that makes it not implant. So think like, what if the woman was a smoker, or the guy was a smoker, or the cycle was all overstimulated and the egg quality was bad, or the guy has DNA fragmentation, or who knows what else, like some other thing. I mean, this is the part that we really don't quite understand, like some other issue with that egg or sperm of that embryo that might not give it the potential to continue to grow. And then in regards to the patient, there could be something going on with her uterus. So there could be issues with receptivity. That's the whole, endometrial receptivity assay, where they try to make sure that the amount of progesterone a woman has received is appropriate and, gives a proper receptive window and timing. They could have inflammatory factors people are looking into, like that are related to either endometriosis or endometritis. She could have a polyp or scarring or some issue going on with or maybe her endometrium looks good on one protocol, but not a different protocol, or it's not thick enough, or it's not trilate, whatever. There's all different things that can go on with the uterus. And then there's other things that could be going on with the woman herself that affects implantation. What if she, has an uncontrolled thyroid disease, or what if she, has elevated hemoglobin A1C, which is associated with diabetes. So I will say that, like, I think the hardest part, like hopefully the next thing we figure out in our field is why genetically normal embryos don't implant, because that's still, I think, one of the tougher parts of our field. We haven't quite figured out, for patients who sometimes have either are young and we think they have genetically normal embryos, or patients who we know we think likely they're genetically normal because they've done testing and they've had 2, 3, 4 embryos transferred. Like, why aren't those people having ongoing pregnancies? I think that's a really tough part of our field we're still trying to figure out. And it's very much in the gray zone. There's a lot of, testing we do and, treatments we do that we're still trying to understand the effectiveness of those things. So, guys, we're going to go for another few minutes here. I feel bad I started late, so we'll go for just another few minutes. All right, hang on here. I want to just touch on, I want to just talk real quickly about recurrent pregnancy loss. That is a very common concern of a lot of our patients, and I did get a question about it. So recurrent pregnancy loss, it used to be a very specific diagnosis years ago. And now it's a little bit more, I don't know if the right word is liberal, but it's really when there's 2 or more pregnancies that have not continued, not ectopics, but not continued and have not given babies. So sometimes even people who have had biochemical pregnancies, it's reasonable to consider doing an evaluation for recurrent pregnancy loss. And I'd say one of the tough things about recurrent pregnancy loss is I feel like a lot of times we know even less about recurrent pregnancy loss than we do about infertility. But there are definitely tests that should be done. So, often we should be looking at hormonal causes for recurrent pregnancy loss, things like checking the thyroid, checking prolactin, checking, and hemoglobin A1C. We should be looking for autoimmune blood clotting disorders. Not all blood clotting disorders, but there's a specific one called antiphospholipid syndrome that we may consider looking for. Other things like MTHFR and factor 5 and protein CNS, not part of recurrent pregnancy loss evaluation, but the antiphospholipid syndrome testing should be done. Sometimes patients will have a karyotype done for them and their partners to make sure there isn't something called a balanced translocation that can sometimes lead to recurrent pregnancy loss, sometimes even in couples who have had children before. I've had that happen a couple times over the years. We also look to do testing for the shape of the uterus to make sure there's no abnormal shape to the uterus, like what we call uterine anomalies, so either a bicornuate uterus or a uterine septum. And then there's a whole lot of other kind of less evidence-based testing that can be done. One of the things, like looking for chronic endometritis and giving progesterone or estrogen, there's definitely limited data on those things. But it is, some people are trying to figure out, like, what is the role of doing IVF and doing genetic testing for recurrent pregnancy loss? And it's really important that if you go down that road of trying to understand, if I have a patient who's had 2 miscarriages, but I have evidence that those pregnancies were genetically normal, like maybe she had a miscarriage and we're able to collect the tissue and test it, like IVF's not going to help that because she's already lost a genetically normal pregnancy. But it may be worthwhile. It's definitely been proven to be worthwhile for people who have the balanced translocation. And, it may be something worth considering also if a woman is, in her late 30s or early 40s, depending on other issues like, any potential issue, like other causes of recurrent pregnancy loss and that sort of thing. I do just want, so I'm going to finish up here, but I know that probably most of our attendees here tonight are from Ohio. And you guys are probably aware, because there's a lot of, things on the news and the media right now. I just want to remind everybody that the ballot issue 1 is very important for patients who are doing infertility treatment and women in general. But, the 2 biggest national organizations that take care of women, so the American Society for Reproductive Medicine, which is the national organization that most infertility doctors belong to, and the American College of Obstetricians and Gynecologists, or ACOG, both strongly support issue 1. And I think as patients who, want to make sure that they get good care, want to make sure they have rights to proper treatment, and want to make sure they have rights to maybe even their embryos down the road, I would really hope that, our patients and their family members be encouraged to vote next week in Ohio. So sorry, I just want to make sure that I got that out there because it's definitely the platform of our national organizations that we should be supporting issue 1. So I wish you all the best of luck with your treatment. And, we're here to help anybody that needs it. And I really thank you guys for attending today, and good luck to all of you. I hope you have a wonderful holiday season and some good things happen to you over the next couple months. Thank you so much.